Thank you so much for being here this evening. Thank you for Simsbury Library for hosting us. Thank you for SCTV for filming this very important forum, addressing a very important critical crisis. On the way here through traffic, I was hearing on the radio today 140 deaths a day due to the opioid crisis. And today or yesterday in the Hartford Business Journal, the quote was, "This crisis is bigger than we think." And often in towns like Simsbury, we don't think this happens in communities like ours. It only affects other communities, but it certainly does affect our community, and we need to address this as a united front, as public officials, elected officials, both sides of the aisle. And we're certainly proud of the legislation that we've advanced over the years on behalf of this issue. But we couldn't do it without the important help of our community stakeholders and leaders assembled here tonight who are really in the trenches of addressing this issue. We have assembled some of the best and the brightest, and I wanted to introduce them, starting at the end, Brad Chase of Simsbury's Police Department, one of the best police departments, if not the best in the state. I'm partial, but Officer Chase does a wonderful job. We have an amazing commissioner of the Department of Mental Health and Addiction Services. She's lifted that agency to great heights, Miriam Delphin-Rittman, and we're so thrilled that you're here tonight. Delighted to welcome Kim Beauregard from Intercommunity Mental Health Group. I used to work for that agency many years ago. It's amazing to see how far that organization has come under your leadership and all the great things that you're doing. So excited to have Sean Lang, Deputy Director of AIDS Connecticut, and her co-director, John Mers, is here tonight, and proud to call him a Simsbury resident. All the great work he does with AIDS Connecticut, raising awareness and much needed funding for that cause. Next to Sean, we have our Director of Farmington Valley Health District, Jennifer Kutanis, and she's going to add her own unique perspective to the conversation. And we have David Messenger, a board member of the Capital Area Substance Abuse Council, to provide his input on the topic. And last but not least, Tom Steen, Executive Director of the Capital Area Substance Abuse Council, and also a Simsbury resident. So we're so thrilled to have you here to talk about your unique viewpoint, but also to get feedback from the community and questions answered, how we can all address this issue together, and hopefully get some guidance from you as a legislator. How do we better proceed to serve your interests as you do your noble work? So thank you all for being here. Thank you to our panelists. And I'm going to begin with our commissioner to start us off. Thank you.
So good evening, everyone. We'll go ahead and get started on this time. So I have also put together just a brief presentation. I'm going to try to go through it in about 10 minutes or so. I have a number of slides, but may skip a few. But I just wanted to provide a little bit of an overview of some of the things we're doing, of what some of the data in Connecticut is showing. Before I start, though, I want to just draw your attention to our Remembrance Quilt. This is a quilt that was put together by family members, loved ones, individuals who have lost people to addiction. Each square is a tribute to a family member. So I just wanted to start with actually a moment of silence, really, in honor of the individuals that we have lost to addiction. We are developing a series of these quilts that we're displaying in schools, in forums like this. This one recently was in Danbury, and our plan is to develop a series of these quilts to help raise awareness and share resources about different programs and initiatives we have here in Connecticut. So DEMAS is, so Department of Mental Health and Addiction Services, we work with about 112,000 people a year. We have a whole network of both mental health and addiction services. We have about 160 private nonprofit providers. And we really do the full spectrum of care, so prevention, treatment, and recovery support services. Let's see here, a different one. Which one is just the straight down? So when you look at the heroin and opiate prices nationally, really what we continue to see, as you all know, is that the numbers just really continue to increase. Heroin, the data suggests, use has more than doubled among individuals from 18 to 25 in the past decade. So that's really an age group that we're seeing significant spikes. We also find it, and we're hearing this in Connecticut as well as the national data suggests, for many individuals, usage started with prescription medications. When we look at the DEMAS data, we find that our admissions for heroin or other opiates have significantly increased since 2011. Prior to 2011, alcohol was also often reported as the primary substance of choice. That is not the case anymore. Now, for individuals accessing our services, often heroin, accessing our substance abuse services, that is, often heroin and other opiates are the primary substance of choice. In 2016, of all the individuals that accessed our substance abuse services, about 52% of individuals reported heroin or other opiates as the substance they use more than others. When we look at overdose deaths, again, unfortunately, our numbers continue to increase in the state. In the past year, 2016, 916 individuals overdosed. And when we look at the different substances that are contributing to that, as you're hearing, fentanyl and some of the synthetic opiates are largely driving those numbers. Fentanyl, some of the data suggests, is far stronger than heroin. And carfentanil, there's some data that suggests it may be up to 10,000 times stronger than morphine. So these are really strong substances. And you'll see, actually, it's probably hard to see some of these numbers, but for example, in 2016, the number of deaths from fentanyl was 479. And then it's broken down, whereas in 2012, from fentanyl, the number of deaths were only 14. So this has been a really significant spike. People often ask, okay, well, so how did we get here? How did we get to a place where there's such a significant addiction rates to prescription medications? And one thing that we're finding is that a lot of the research and literature talks about how within the medical field, often pain is talked about as in many ways, the fifth vital sign. We all know we go into a doctor's office and the physician may ask, what is your level of pain, and we're asked to rate it on a scale. So in the medical community for years, it really was encouraged to appropriately treat pain. And that's some of what contributed to the high rates of opioid prescriptions. In addition to just high manufacturing rates. 2011 data suggests that over $320 billion were contributed to pharmaceutical sales. So 320 billion, that is a lot of medications. In addition to prescription medications, of course, heroin. For individuals that are on prescription medications, they may reach a point, because of prescription monitoring program, or they may run out of their prescriptions, and a scenario that people often report is then heroin. because heroin is less expensive, it's more easily accessible, and what we're finding is the purity rates are as high as they've ever been. And then same thing with synthetic opioids. They're even less expensive than heroin, but way more potent. So again, the fentanyl, carfentanil, and other synthetics like that. There's a group of folks that do work here in Connecticut and really all over the Northeast. So the HIDTA folks, so high intensity drug trafficking area officers. I was at a presentation recently and they talked about how there have been instances where dogs, so the dogs that sniff packages at either airports or at post offices, that those dogs are overdosing because now fentanyl and carfentanil is being shipped in the mail, and the vapors from it alone, in some instances, have caused the dogs to get sick. So these substances are extremely potent, and so that's contributing to some of the high both overdose rates and for some individuals addiction rates. When we look at some of the numbers here in throughout the state, in terms of individuals accessing our services, again, we do see an increase. And these are individuals that are coming in and reporting heroin or opiates as among the substances that they use. So you can see some of the numbers for Simsbury. In 2012, just straight admissions were around 40, and 2016 around 51. When you look at our overall rates, 2012 for the state of straight admissions, and these will include duplications, so some people that may be admitted more than once, 21,000, and 2016, 27,000. So we're continuing to see those spikes in people coming into our services. In some ways, maybe that's, we certainly want people to access services. So what that lets me know is that people are trying to get help. People are trying to achieve recovery. And so that's not a bad thing. Certainly we want the numbers to go down, to go down, period. But the fact that people are accessing services, if they're struggling, is a good thing. So just some things that are going on in Connecticut, since 2011, really. I think there's only been 1 year, and that was 2013, where there wasn't legislation. But since almost every year, significant legislation has been passed addressing different aspects of this crisis. So into this past year, there was legislation that was passed that reduces the maximum number of pills that can be prescribed for first-time prescription for minors from 7 to 5 days worth of medication. So that's pretty significant. And we know that there are a lot of unused medications out there. And so reducing the availability of and reducing the numbers of pills that individuals can get for a first-time prescription is pretty significant. This bill also talked about data sharing across state agencies to better track a range of issues, trends, Narcan use, and just to track a range of issues, and then other areas. Another issue addressed with this is the ability of individuals to sort of have an opt-out option, to say that when they're meeting with their physicians, that I'm not interested in being prescribed an opiate in an instance if they need pain medications. I'm interested in other options or other possibilities being explored. And there's quite a bit of discussion about that right now. So things like acupuncture, massage, some of the complementary and alternative approaches. So, okay. I'm going to go through some of these. Actually, I'm going to skip some of these. The two slides that I'm skipping, just in the interest of time, they're just talking about some of the state planning efforts. So one piece is, I chair, along with Commissioner Katz, from the Department of Children and Families and Alcohol and Drug Policy Council. That's a diverse group of individuals, including family members, people in recovery, ED docs, representatives, senators, and the goal really and charge from the governor has been to come up with a series of really action areas. And so this group is really action focused, working in the area of sort of prevention, treatment and recovery supports, and recovery and health management. And in a bit, I'll talk more about some of the work going on through that group. CORE initiative. This is another similar planning initiative that is addressing a range of areas, including increasing medication-assisted treatment within prison settings, increasing access to buprenorphine or naloxone. And this is an initiative that's being carried out by a team from Yale. It was charged by the governor, and we're working collaboratively with them on implementing many of the areas outlined in this report as well. So I'm just going to talk about some of the other areas of work that we have going on. I probably have about 5 more minutes or so, or maybe just a little bit more time. So one is, we have a range of sort of prevention related activities, and prevention and some moving into treatment. I would say this first one is sort of prevention, but also moving into the treatment area. We have a 1-800 number, and so that number is here. And essentially, somebody can call that number and be linked with somebody who will call around to different services so that they can receive an assessment, and then also if they need detox, receive a ride. So we're calling it sort of a warm handoff and a ride. So if an individual needs detox, we'll give them a ride to detox or another level of care. Once the individual on the phone finds an appropriate treatment level for them, we'll give them a ride if necessary. And we're seeing quite a bit of people access this new resource. The number's been around for a while. The new piece is the ride, because we know that in many areas of the state, transportation is a challenge. The other thing we're doing is quite a bit with social media and messaging. So we have a Facebook page where people in recovery have been sharing their stories, and we've been getting quite a bit of traffic with those. I think it's been a nice way for people to share their story and to let folks know that recovery is possible. You can get to the other side of this. And so if you're on Facebook, certainly go to our DEMAS Facebook page and take a look at those. Some of them are just really powerful, and I believe just such a gift for us to be able to have those firsthand accounts of people's experiences and recovery journey. I'll continue on. The other thing we're doing is we're applying for, because certainly fiscally there are challenges, and so we're applying for everything that we can in terms of federal grants. And recently received a grant from SAMHSA, so the Substance Abuse and Mental Health Services Administration, and this is their S2TR grant, so their State Targeted Response Grant that's funding a range of treatment, prevention, and recovery-related initiatives statewide to address this issue. So things like having people in recovery partnering with emergency departments. This is an initiative recently that we've seen really significant positive outcomes in terms of so when an individual is brought to an emergency department, they're connected with a recovery coach, and the recovery coach often then lets them know about services or treatment. Sometimes at that moment they're not necessarily receptive, but the recovery coach will call up to 3, 4, 5, 10 times if necessary. And some of our recent data suggests that, or shows that out of 372 people that the recovery coaches have connected with, they've been able to link 352 individuals to treatment. And so that's really significant. And for the individuals that aren't linked, they continue to make phone calls. So we're interested in scaling that up wherever we can. Because of this funding, we'll be now expanding to 7 hospitals. We're currently in 4, actually about 5 hospitals now. So this is that initiative, the recovery coach and the ED. The other thing that's striking about this is that the hospitals, there's a system change that we're seeing within hospitals. In some instances, the hospitals have invited the recovery coaches to have an office there in the ED. And so that's a pretty significant addition to the project, which wasn't part of what we initially conceptualized. And actually, the people connected were 367. So I think I said 350. It's actually 367. So they're really seeing pretty significant connection rates there. These are just the different levels of care that we offer throughout our system. So detox, different forms of residential, intensive outpatient, recovery houses, and then medication-assisted treatment is offered around campus as well, or around the state as well. This is more on medication-assisted treatment. So there are different forms of MAT. So methadone, buprenorphine, and Vivitrol. They're all a little bit different. And with methadone, individuals often have to go daily, but they can receive sort of take-home doses. With buprenorphine, it's often available by prescription, and an individual may not have to go daily. Actually, they don't have to go daily. And Vivitrol is available in a monthly shot. And then these are just some of the community. We have community recovery community centers where people in recovery staff and run these. So CCAR runs these community centers, and essentially they're drop-in centers. They have recovery meetings, recovery trainings, family support groups. They offer recovery coaching and a range of recovery-related social events. And then, as I mentioned, the Remembrance Quilt. We've been having a series of quilting events really around the state where people can sort of come together, share stories of their loved one, and develop a tribute for their loved one. We currently have probably 3 other quilts that are in process, and I noticed the quilts around this room, and we're always trying to recruit quilting groups and individuals that are interested in quilting to come on board with us. So I'll stop there. Oops, did I do that? Yes, anyway, I'll stop there and be happy for questions and discussions later on.
So good evening, everyone. As John introduced me, I am your health director for the town of Simsbury. How do I turn that into the full screen? Let's just give me 1 sec to concentrate. There we go. It's my pleasure to be here, and thank you all for coming out to talk, hopefully have a little bit of conversation and talk a little bit more about this really important public health issue. As the Farmington Valley Health District, most people... What's going on there? Is that? So most people know the Farmington Valley Health District from our regulatory functions in food service in particular. And I can tell you, while that's really important work, that's not what brings me the most passion. My passion in public health is really around disease prevention and health promotion. And one of the things that your local health department is really responsible for doing is monitoring diseases that are causing the most significant premature deaths and illness and burden on our communities. And you're all here because you recognize that this is a very significant public health issue. We describe it as a public health epidemic in our communities, and we have a lot of work to do. As you've heard from our commissioner, prescription opioids and heroin misuse and abuse and overdoses have increased quite dramatically to the point where we are now calling this a public health epidemic. And for some perspective, if you compare what we're seeing in terms of accidental drug overdoses to automobile-related deaths or firearm deaths, it is nearly 2 times as high in 2016 as those automobile and firearm related deaths added up. And while those things have steadied off over the last several years, the drug related deaths are continuing to increase. So we look at this and wonder, why are more people not sitting in these seats thinking about the implications of this to our communities? In public health, we're very interested in risk factors and understanding what are the risk factors that are contributing to these premature causes of illness and death. And this slide is really quite interesting and upsetting at the same time, because if you look at in the blue, you can see that our opioid-related deaths were somewhat stable up until, and in some years actually decreasing prior to 2011. What happened around 2010, 11, and 12? We saw significant increases in prescription opioids, and correspondingly, we are now seeing a significant rise in the heroin-related deaths. So we're seeing that direct correlation that the Commissioner talked about in terms of prescription opioids, increase in prescription opioid use, abuse, leading to addiction because it is a powerful, mind-altering drug, leading and contributing to our heroin epidemic of today. So very, very sobering and drawing the relationship between this prescription opioids and the heroin epidemic. In public health, we're also very interested in the who. Who is at greatest risk? And so these next two slides, this one speaks to prescription opioid deaths over a 6-year period. And again, you can see that dramatic increase in prescription opioid-related deaths as they became more widely prescribed by providers. The highest rates were seen in white non-Hispanic men, but in females, particularly around the 40 to 49-year age range, their rates of death associated with the prescription opioids are approaching that of their white male counterparts. In this next slide, we look at heroin-involved overdoses, and you can see the age group that is most adversely affected is shifting to younger ages, and we see far more males dying younger because of heroin-related overdoses, and we think that there is some aversion among females in general, not all, but to injectables, so that may be why we're seeing more related to prescription opioids as opposed to the heroin specifically. In the Farmington Valley, I just wanted to show you the numbers aren't dramatic, but these are human beings. These are people that are dying before, before they should. And we are seeing in the green column almost a doubling of the deaths in the Farmington Valley, which includes Simsbury, in 2017, and we're only halfway through the year. So it is here, and it is increasing. As an epidemiologist, I like to talk about the fact that often we don't understand, or there's no single source of data that provides us with an understanding of the full burden of illness, and the deaths are just the tip of the iceberg. They're readily accessible data, but we know that the burden of this disease is far greater, and the at-risk populations are not reflected well in some of the hard data that we have, for instance, the deaths that we see in the Farmington Valley. So, to really appreciate the full implications and the burden, we also like to look at these risk factors. And so, just a few things here. The misuse and abuse of prescription medications like opioid-based drugs has increased significantly over the years, and this is contributing to this rise. They're saying that as much as 80% of the heroin-related addictions started with prescription opioids. So again, breaking that cycle, being more conscientious about our prescribing practices and uses is really important. The other thing I want to talk about a little bit in just one side is the relationship between mental health and drug use and misuse, and it's another confounding factor. And if you think about the population that may be at risk of drug use, abuse, and ultimately, unfortunately, deaths, it's people with mental issues are at greater risk. Nearly 20% of all adults report having some depressive disorder at some point in their life. That's 1 in 5 of us. That's a very large group of people that are at increased risk. In addition, individuals that have mental illness are 3 times more likely to have a substance abuse disorder. So again, it's that bottom of that pyramid that we're worried about. 35% of adults report more than one adverse childhood experience, and we know this significantly increases the risk of both mental illness, mental issues, as well as behaviors, at-risk behaviors that may include substance abuse. And nearly 9% of young adults between the ages of 18 and 25 reported non-medical use of pain relievers. And I want to talk about kids, teenagers in particular. There is really something critical happening between the 9th grade and 12th grade. And between those grades, there's almost a tripling of the percent of students reporting ever taken a prescription drug to get high. And for the high schoolers, it's as much as 18% of that population that have said that they have taken a prescription drug to get high. There are perceptions among all of us, especially our kids, that prescription drugs are safer. They're prescribed by a physician, therefore they won't kill me, they won't hurt me, etc. We know that not to be the case. 11% of students have taken a prescription drug, attention deficit disorder, drugs, etc., not prescribed for them for purposes of getting high. So again, when you think about the populations at risk, we need to be thinking about what our kids are telling us about their use of drugs. It is a very complex issue. And there are many tools in the toolbox that we need to employ in a very cohesive and collective and comprehensive way if we're going to tackle this issue. It is imperative that Narcan, and you'll be hearing more about this from Tom and others, that Narcan is available as an intervention to save people who are in crisis from dying. That's very important. It is really important that we have prescription monitoring programs in place. It is important that people have access to treatment when they need it, where they need it, in affordable ways, in consistent ways, etc. And it's important that they have ongoing recovery support. As public health, we really also need to look upstream at prevention, at what is creating populations that are moving down into this stream. Because I can tell you, anyone that is dealing with someone with addiction, dealing with recovery, would much rather have looked way upstream and figured out how it could have been prevented in the first place. And that's challenging and that's hard. I don't have all the answers, but it's going to take all of us working collectively, and we can't lose sight of all of these elements as we move forward to try and address this major public health challenge. So thank you.
Hi, everybody. My name's Tom Steen. I'm the Executive Director of Capillary of Substance Abuse Council. I welcome you all. I'm going to go over some overdose prevention things really quickly. What you're going to see usually takes about a half an hour, but I'm going to put it in less than 10 minutes. It could be life-saving for you. As we heard from Jennifer, this is a public health issue, so we really need to prepare ourselves, especially if you think there's somebody in your family that potentially could be in trouble. What you'll see is actually a train the trainer program by the Massachusetts Department of Public Health in cooperation with the Center of Social Innovation. I've chose this one because it's really simple and direct and understandable. Here's what the plant looks like. It's a beautiful plant, the opioid plant, but as you can see, there's opiates, which is the plant side of it, the semi-synthetic, and then the synthetic, and you can read the slides. So the amount of drugs that is all connected to this opioid issue is huge. The duration, the different durations of heroin compared to oxycodone or some of the other, you can see the different hours. But then you can see the potency, and I point to you the bottom one, which is fentanyl, which is really dangerous. And and we'll hear from Officer Chase today. But we're finding is the heroin or the cocaine is being laced with this fentanyl, which is what's causing these deaths in our communities. This is how opioids are used by somebody that's under the sense of addiction, and you can see it. Back in my day, injection was, the person who addict was under a bridge with a needle, and obviously that has changed here in recent years. Here's some signs of opiate use. These are some of the things that you could see in somebody who are beginning to use opiates and might be leading them down the road of addiction. And they're pretty simplistic when you look at them, and certainly the more of these signs present, the more at risk. Here are some of the consequences of opiate use. The increase in tolerance, and it has a lot to do with the brain chemistry, which we're not going to go talk about today. But the brain receptors, these opioids attack the brain receptors, and they need more and more and more and more of it. Why the tolerance goes up, the dependency, and then the progression. And David's here today. I'm going to let him talk about that. As he is in recovery and on his journey on how his addiction progressed. Opioid withdrawal symptoms. So now somebody that is in the thralls of an addiction will go through some pretty severe symptoms as far as withdrawal, and you can see all of these that are quite visible if there's somebody in your family that's suffering from withdrawal. Here are some intoxication of distinguishing intoxication from overdose. How somebody would look really high on an opiate as opposed to somebody really going into a full-blown overdose. And the key thing is the deep breathing. We know that somebody that's in the thralls of an overdose, their system's shut down. They stop breathing. And so a lot of these things are symptoms, but the key one is the stopping of breathing. When overdoses happen, it can happen within minutes or hours. It may happen quickly when it's that fentanyl. And by the way, fentanyl is used to put elephants to sleep. That's how dangerous that stuff is. It scares me. And periods of abstinence. So if somebody is who decides to go into recovery and then has a relapse, they take the same amount as they were back when they were full addict. Well, that immediately puts them in danger because the body can't handle it. And of course, new dealer, post incarceration, new route of administering the drug, where they go from snorting to maybe needles. So all things to look at. Top overdose risks involved, misjudging the body tolerance, so thinking they can take too much of it or take more of it and be okay. Using drugs along, mixing drugs and alcohol. Poor physical health goes without saying, and certainly mixing stimulants with the opiate can also be very, very, very much at risk for the person who's addicted. Signs of an overdose, and these are pretty important things to look at when you think you've come across somebody who's in an overdose. These are the key things to look for, and there's that deep snoring or gurgling, they're breathing, they're stopped breathing, a slow heart rate, the body is beginning to shut down. and literally falling asleep when in their throes of an overdose. And here are the most critical signs: unresponsive and unconscious. And Officer Chase will talk a little bit, I'm sure, about that on the panel today. And the breathing is slow, or maybe has stopped, and they were actually turning that grayish or that bluish tint, and which is really the danger point as far as overdose. Responding to an overdose, obviously you call 911 right away. Rescue breathing. Remember, when somebody's in the throes of an overdose, the breathing is stopping. So we want to try to get oxygen into their system. We're going to talk about administering naloxone, which is the Narcan. That's the the company name for, and there's several different companies that do naloxone. Certainly stay with the person. And we're going to talk a little bit about the recovery position, because it's really important. And before first responders get there, you should know how to do this so that you can save a life. Here's what you do when you call 911. My friend's unconscious, not breathing. I'll give exact location. There's no need to say that they're in a heroin or in an overdose situation. The first responders will know when they get there what to do. And then certainly stay with the person until help arrives. Here's an example of rescue breathing. It's tilting the head back, pinching the nose, and then giving a breath every 5 seconds. If you're CPR trained, they talk about now 10 breaths, I believe. No need to do chest compressions. That's not necessary in this particular case. Just trying to get oxygen into the system until first responders arrive so that they can administer Narcan, or if you have it, you can do it. There's a little bit more about the rescue breathing and 4 or 5% less oxygen when you actually do rescue breathing. It's not full oxygen that you're putting in that person's lung, so that's why you have to keep doing it. And quite frankly, putting oxygen in somebody's system keeps the oxygen level up in their system and avoids brain injury or damage. Give oxygen, do rescue breathing. In the kits that we hope to distribute here through the STR grant that the commissioner talked about, that's just being rolled out now, there's actually kits that have mouth guards, they have all rubber gloves, and they're going to have 2 doses of 4 milligrams of Narcan in the nasal, which is the easiest way to administer Narcan system. More about that in a second. Here's the recovery position. When somebody's in the throes of an overdose and they're laying on the back, they could easily suffocate themselves, either by just stop breathing or vomiting. So the way to do it is, and you can see the diagram here, is kind of put the arm up, and then what you want to try to do is roll the person onto their side, and that will help to keep the air passage over until first responders can arrive. Here's kind of the 1, 2, 3s of it. Call 911, rescue breathing, and if you have Narcan or naloxone available, administer it. It's 1 shot, up 1 nasal, 4 milligrams. And the thing about naloxone, it's a simple spray. It has no effect other than blocking opioids. It's not addicting. It won't hurt somebody if you do give a Narcan a dose and it wasn't applicable to it. It won't hurt the person. So when in doubt, if you think the person's in an overdose for an opioid, give the dose. Here are the different examples of it. Naloxone formulas. The one that the state is now really kind of pushing now, especially in our statewide initiative, is the Narcan spray, which is the simple step. You don't have to put anything together. You literally take it out of the box and give the dose. Now, to get a dose of Narcan or naloxone, you can go to the pharmacy, and by state law, the pharmacist is now allowed to issue and so you don't have to go to your doctor to get a prescription for it. Our pharmacists are now allowed to do it. The person wakes up within 3 to 5 minutes, and I'll let the officer talk a little bit more about that today. It is absolutely, it's a miracle drug when somebody's in the throes of an overdose. So I'll let him talk a little bit more about that. It can't harm anybody. It's routinely used by EMS and emergency, and it's available in most Connecticut pharmacies now. So it's something really important. Timing, the duration of how it lasts, 30 to 90 minutes for most particular cases. The problem is if you're over 18, you can refuse treatment. And I've spoken to many first responders that end up going back 2 and 3 times because the person's overdosing again. Either they're taking more overdose or taking more dose because of they're in the throes of addiction. So it's really important to get somebody to the hospital so that they can be treated for the addiction. And as the commissioner talked about, this really cool new program called Recovery Coaches is really making an impact because somebody that's in recovery with the stigma and all that, will they see somebody in the emergency room that's embracing them and supporting them and not being judgmental, opens the road to begin to have that conversation that maybe there's a different direction to go. Really important. Here's the 8100, DEMIS 8100 number. I have flyers on the back table you can take with you. 911 is obviously certainly emergency. 211 is for young people under the age of 18 because we have a system in our state. It's called the EMPS, and they're the emergency psychiatric response teams for youth. And they respond within 45 minutes to help somebody and help families. And so do utilize it. And it all goes right through 211, which is, and 211 is manned by counselors and by social workers 7 days a week, 24 hours a day, for both adults and youth. So do remember that. It's a critical thing. So that's me. I went fast. I'm going to introduce my colleague David, who is a member of our board of directors at KSAC and a dear, dear friend. Thanks, Tom.
Hi, guys. My name's David Messenger. I don't have a slideshow, unfortunately, so you guys, I guess I'm more of the human slideshow tonight. When I first started doing public speaking about addiction, about 20 months ago, actually, which tomorrow will be, God willing, my 21st month into recovery. I started doing public speaking. Thank you. When I started doing public speaking, I really focused on my story of what it was leading up to addiction, into addiction, and then as I've gotten into recovery, I've really found that my story has changed in a lot of ways. How I got here hasn't, and I'll answer the question before anybody asks. I wouldn't change anything that I went through, because without going through that, I wouldn't be here right now. The only thing I would change is I wouldn't have my kids have to go through what they went through. But I'm not going to bore you with a lot of war stories tonight. I'm basically going to take you through an inside look into my nightmare, and then I really want to talk about what my life has become after active addiction. When I was looking at the commissioner's slideshow, it was like my life to a T, with the one very big exception. I don't come from a broken home. Thank God, officer. I've never seen the back of a police car. Never been incarcerated. So that is kind of where I differ from a lot of your normal or your typical addicts. The fact that none of those things ever happened probably kept me in addiction a lot longer. My story started like a lot of people's story with addiction. It started in somebody's basement because we were told we were going to be safe. We're not going to be on the streets. We're not going to be driving a car. And it started with a red Solo cup. Drinking. I'm not a huge person that's going to talk a lot about gateway drugs, but what I will talk about, in any addict that discusses it openly, is addiction is a disease of progression, and it certainly was with me. I started off with alcohol, dabbled a little bit with marijuana. I couldn't take marijuana because it made me crazy paranoid. So basically what I said is, I'm going to be even better, and I'm just going to go right past that step. So I went from alcohol straight past marijuana into cocaine. Now here's where the fun part happens. 22 years old, I had a freak accident. I swallowed a chicken bone, and I perforated my colon. Long story short, 10 abdominal surgeries later, I am on prescription drugs, and every prescription drug that was up there, I've been on in excess, abused, and taken the way I'm supposed to. And there's one that I really want to talk about, and that's fentanyl. Because being on fentanyl, without a doubt, saved my life. I was on fentanyl for over 12 months, the patches. I was on a 72-hour patch. The first 36 hours of that patch, if you even said the word food, I would get physically sick. How did that save my life? When I went to heroin, anytime I came across a batch of heroin that was laced with fentanyl, same response. So I knew not to take it. I know that sounds a little bit weird, but I'll get into that a little bit later. I was what you would call a functioning addict for a long time. I ran entire car dealerships, started off as a salesperson, went all the way up to general manager, all while I was in the throes of addiction. Obviously, as my addiction progressed and got worse, the best way I can describe it is I got lost. And some of the signs that Tom talked about, the biggest one with me was my withdrawing from my family, from my now ex-wife, from my kids. When I went into recovery, the most sobering moment that I had was realizing that the first moment that I spent with either of my then 18 and 17-year-old son and daughter, first time I ever spent any time second clean in front of those two kids, was when I sat with them for my first visitation at Rushford in Middletown. If you think about that, I was there for a lot of what happened when they were growing up physically, not mentally. I mean, I was so checked out by the time I was done with my active addiction that I was just a shell of my former self. I can tell you right now, David Messenger from 2015 would never be standing in front of you. I would be in a basement somewhere, and my sole existence was feeding my drug addiction. I'll take you through a typical day in my life leading up to what caused me to go into recovery. I would get up in the morning, and I would go through probably about 3/4 of a bundle of heroin, which a bundle is 10 bags, so about 7 bags just to get out of bed in the morning at 6:15. Get in the car, put my kids in the car, take them to school, come home, do the rest of that bundle, probably plus another 1/4, pass out till about 1:30 in the afternoon, get up, do another half bundle, get back in the car, drive to school, pick them up, come home, and do nothing. That was my entire existence for probably the last 3 years of my active addiction. I'm not proud of that, and the reason I talk about that is when I see where I started out, where I went to, and now after active addiction, what I've kind of gotten into and where my life is, the direction my life is going in now, it's pretty crazy actually to think that some of the stuff that I'm actually doing now. My addiction, without a doubt, started with prescription drugs. That being said, I am never in a million years going to stand up here and try to blame a doctor or a healthcare provider for my addiction. 10 abdominal surgeries. I was on crazy amounts of opiates, but I was also in a crazy amount of pain. My last surgery, which was in 2007, I had a hernia repair where they had to rebuild my entire abdominal wall. They put a mesh in, and what happened was they entrapped some nerves. So constant pain. The reason I don't blame a doctor, and I never would blame a doctor, is there are people that need to be on narcotic pain medications. It's the world we live in, and that is not going away. The problem is the doctor didn't give me 30 days worth of drugs and tell me to go through them in 10. Now, when that happened, the natural progression was to heroin. One of the things that I believe Karen said was that nobody wakes up and says on a Tuesday morning, I'm going to become a drug addict. It is a disease of progression, and it's about self-medication. It's with me, I was probably depressed the entire 20 plus years that I was in active addiction. Never thought I was, because, hey, I was getting up, I was going to work, I was making money, I was doing what I thought was what I needed to do. Only through getting into recovery did I realize that how bad it had really gotten, and that it's okay to admit that I have a problem. The biggest issue with our society right now, and I'd applaud everyone that's sitting in this room, because let's be honest, this isn't fun. This isn't a topic that anybody wants to talk about, and unfortunately, the first time a lot of people will talk about it is when it hits their families or it hits somebody close to them. So the fact that you guys are sitting in this room right now is a good thing. And the work that organizations like DEMAS, like KSAC, like healthcare providers do is essential. And without it, and without funding for those things, this epidemic that we're in the thralls of right now isn't going to get any better. In fact, it's probably going to get a lot worse before it does get better. So I'll get off my soapbox as far as that goes. Now let's talk about some fun stuff. My life over the last 21 months. Went from doing my day-to-day routine that I talked about to now, at 46 years old, have gone back to school. I started at Westfield State to become a drug counselor. This is my passion, without a doubt. It's one of the things that you learn in recovery, is that you can only keep your own recovery if you try to give it back and try to help others. And when I see what's out there and what's on the streets, when they're cutting the drug with a drug that's sometimes 500 times more powerful than the actual drug, that's pretty crazy to think about. So that's the first thing I did. And it took me about a year into recovery to realize that I really wanted to do it. In addition to doing things like this, going out and speaking in the public about my story and trying to prevent somebody from walking down the road that I walked down. The other thing that I did, and I did this 3 months ago, was decided to get back into the workforce. I didn't choose to go back into the automobile business because I didn't want that type of pressure, and my main focus is still to become a drug counselor. So at 46 years old, I became the guru of the drive-thru at a local Dunkin' Donuts. Now, if you told me at 46 I'd be working at a Dunkin' Donuts, first of all, I'd be like, what went wrong? But I got to tell you something. I absolutely love it. I go to work every day. I work with the public. And the one thing that I've found over the last 21 months is I've refound my voice. I'm not the withdrawn, I've never been shy. Obviously, if you guys can hear me speak, you can tell that. But I'm not withdrawn anymore. I enjoy working with people. I enjoy that job. I get up at 5 o'clock in the morning to go to work, and I'm done by 12 in the afternoon, and I have a blast doing it. And this is going to really probably blow some people's minds, but I can see myself staying and keeping that as a part-time job once I become certified to become a drug counselor. And, you know, something, life is good now. I've reconnected with those 2 kids. And the reason I was able to do that is when I sat in that visitation room at Rushford, they looked at me and they point blank said, "Dad, we don't care what happened. We just want you back." So my main focus in my recovery has been to reconnect with those 2 kids and try to repair the damage. It hasn't always been easy. There's been certain times where they're like, "Well, Dad, you're so different now." And I'm like, yes. And there's times where they want to bring up the past. And let's face it, they have every right to. I dragged them through the mud, and I put them through living hell. But one of the things that I try to work on in recovery is I can't change what I went through. I wouldn't change it. But like I said, I wouldn't put the kids through it because they had to grow up way too fast. But one of the things that we've kind of come up with is that we talk about how to move forward. If you continue to try to blame somebody for something that's gone on in their past, then there's no healing process, there's no moving forward. Last thing I'm going to talk about is the stigma. As I stand in front of you guys right now, you probably wouldn't guess that I was a 4 bundle a day plus 350 milligrams of prescribed opiate abuser per day by looking at me. That's the biggest thing that the world and our country and local communities have to wrap their minds around. This problem isn't in the inner cities anymore. It's not just in the inner cities. The typical drug addict that you see nowadays isn't the guy, like you said, Tom, living in a cardboard box under a bridge. It's your high school students. It's your college students, young parents, retired people. This disease does not discriminate. And the reason I use the word disease is because this is the only disease in the world that we let the person get as bad as humanly possible and as close to death before we treat. If somebody had diabetes, the first thing they're going to do is they're going to set up a treatment plan. They're going to do that immediately. Cancer, any other disease. This disease, we wait until the person hits rock bottom. I don't believe in rock bottom. There's only one rock bottom, and that's death, because anything else you can come back from. I'm living proof of that. But the stigma that's out there is still that these people are losers. They're not. They made a choice. Let me tell you something. When you are addicted to heroin or opiates, it's not a choice. It's not about getting high. And that's the one thing that nobody will tell any of the kids in your community, my community, any community. It starts off as fun. It starts off as getting high. When you're hooked on opiates, you're not high. It's just about being able to function and not be sick. And that's, I think, a very big thing to point out, because this generation that is out there right now is so fearless. They're not afraid of anything. Nothing scares them. When I was in high school, if you told me, anybody mentioned the word heroin, no, that's the guy that's the homeless guy living under the bridge. Now, oh yeah, let's try it. That alone is scary as hell. But getting back to the stigma fact, these people, myself, others that haven't found recovery yet, there's somebody's father, there's somebody's brother, there's somebody's sister, there's somebody's husband, wife. They deserve as much respect as anybody else in the world. And until we start breaking down the barriers of stigma, I don't think the problem is going to get much better. Like I said, this isn't a fun thing to talk about. but it's a necessary thing to talk about. I thank you guys for letting me speak. I appreciate it.
Come on, perk up. I know it's late. You've had a long day. We all have, but we're here together, so let's jump right in. So I'm Shawn Lang. I'm the Deputy Director with AIDS Connecticut. I've been with the organization for about 26 years now. I always tell people that I get to do what I love to do the way I want to do it, and I wear cargo shorts during the summer, and I get to work with John Murs. So that's a pretty damn good job. So about 4 years ago, some legislation changed to make it easier for people to access naloxone. And it allowed a physician, APRN, PA, to write a prescription for naloxone to anyone. The legislation prior allowed them to write a prescription to a known drug addict. And there's an inherent problem with that, which is, if I'm in an overdose, I can't get myself Narcan. So by making it available to family members, or anybody actually, they could have it available. Because we all know, we talk to people all the time who have an affected family member, a friend, and they're worried about them overdosing, but they didn't know about Narcan. So I'm in a meeting. One of the programs we run is a syringe services program funded through Department of Public Health, and I'm going to talk a little bit more about that in a second. So we're at a meeting, and I said, well, who's doing any work to promote this so that people know about it? Crickets. So necessity is the mother of invention. So we started a statewide opioid overdose prevention work group and brought together people from DEMIS, from Department of Public Health, Department of Children and Families, DSS, Department of, did I say Public Health? Public Health, affected family members, people who work in treatment programs, and it's really grown. You know, people say, oh, can I invite so-and-so to come to the next meeting? I'm like, it's open. It's not a closed group. Bring anybody you want. So we have people from the Department of the Office of Emergency Medical Services from DPH. We have a doctor. We have an EMS guy who's awesome. We have Kelsey Oposa from HIDA, who's been terrific. And the main priority of the group is to promote the availability of and access to naloxone. And so we've branched out into other areas as well. You know, so couple people mentioned that Narcan's pretty widely available in pharmacies now. We always recommend that people call first to make sure the certified pharmacist is in-house and that they have Narcan in stock. And if they don't have Narcan in stock, they can get it in about 24 hours. And if somebody's on Medicaid, there's no copay. And if you have private insurance, the copays are going to vary. So you want to ask for the nasal option. So the other thing, a couple of other things I want to talk about too with regard to that. People always ask about liability. Well, I'm just a lay person. You know, what if I give somebody Narcan and they die? There's no liability. You know, and as I think Tom said, you know, there's no other effects to Narcan. Its sole purpose in life is to bring somebody out of an opiate overdose. You know, we went through Tom's presentation. I mentioned our syringe services program. We started doing community distribution of Narcan with our clients about 4 years ago. And we train them on the fly. They're coming to the van and they're bringing their used syringes and they're getting clean, sterile syringes back. They're getting other support services. We test for Hep C and HIV. And we ask them if they want to get trained on overdose prevention. And many of them do. And we have the nice little red kits with all the stuff inside. But they don't want to chit-chat. They don't want to spend a lot of time. They have things to get back to during their day. We train them with it in 5 to 10 minutes on how to recognize an overdose, how to respond to an overdose, how to administer Narcan. Our clients have saved over 300 lives out in the community. And one of the reasons I mention that is because they're just regular people. They don't have any medical training. And remember, we're training them on the fly, out on the street, on how to do this. So it's really important to remember how easy it is to do, you know, to administer Narcan. One of the other things I want to say, people, you know, different people talking about how do we get here, and you know, there's lots of thought, lots of theories, lots of data. But a couple of things have happened. Until recently, there were only 4 medical schools in the whole country that had required coursework on pain management and how to safely prescribe opiates. So we had lots of well-meaning providers, some of whom, and we've seen these in the news, writing prescriptions for opiates like Skittles. And opiates were never intended for long-term pain management. They were designed for end-of-life cancer pain. But we've seen this proliferation of opiates into our communities. Probably many people in the room have opiate prescription, unused prescription, sitting in their medicine cabinet. Dispose of it. Dispose of it. I don't know, does the police department have the drop box?
Yes, we do.
So you get a drop box right here in town. You can dispose of any of your unused prescriptions. So that's an important piece to understand. The other thing, I talked about liability. There's a Good Samaritan law too. So if John and I are using drugs together, like we always do, and one of us overdosed, the other one calls the cops, there's always a worry that when the cops come, they're going to arrest both of us. Well, you're calling in the course of saving somebody's life. They can confiscate all your stuff, but they can't arrest you unless you have an outstanding warrant. And that's an important thing, particularly for our clients, because a lot of them have had histories with the criminal justice system. So we want to, help them stay safe. Recently, there were some changes in legislation that required all first responders. I know we're going to talk more about first responders carrying Narcan. To do that. The state troopers have been doing it for a long time, and they report back to Department of Correction because Dr. Maurer, who's the medical director there, his name is on their standing order that allows them to carry it. And recently, there was a press conference last week. All college campuses, public safety, will be now carrying Narcan. And I just want to give some props to Mark Ojakian, who's the president of the Board of Regents, for being so open to helping make that happen. Of course, he says it's because of me. He said, well, when Sean asks me to do something, I have to say yes. I can't say no. A little more on the data. In opiate overdose deaths, we work with researchers at Yale to examine the opiate overdose death data from the Office of the Chief Medical Examiner. So it's 70% male, 84% white, with a mean age of 40 years. And we talked a little bit about the 2 clusters, kind of the 18 to 24-year-olds, and then the cluster, which tends to be older women. There's 70% were pharmaceutical opioid involved, and we don't know if they're legitimate prescriptions or not. And I could tell you from helping to examine that data, most people did not have one single substance. There was multiple substances in their tox reports. There was an increase in heroin between 2012 and 2015. Some of the theory behind that is that Oxy was reformulated in 2011 to make it harder to crush and snort, which people often did as their kind of gateway. And as we've heard, it's much easier to turn to heroin, which is plentiful, very pure, and very cheap. Benzodiazepines were involved in 42% of the deaths, and we're paying a lot more attention to that. I had a little side conversation with Kim that I'd read an article somewhat recently about concern about older women overdosing. A lot of folks, again, have prescriptions for pain management, and a lot of older women have prescriptions for benzodiazepine, for anxiety, for insomnia, and they're a very deadly combination, and they might be getting those prescriptions from 2 different doctors. So there's a miscommunication there. So that's another piece. And then 44% of people who died had histories with Department of Corrections. One of the things that we know is that people are most at risk of overdose when they come out of treatment and when they come out of prison. And again, it's because they've been abstinent for a period of time. Any period of abstinence, whether it's by choice or by force, leads people to be at higher risk of overdose. The last thing I want to talk about is, so this is all the good stuff that's happening. Looking ahead, what are some of the things we want to see happen? Almost everybody up here has referred to this as an epidemic. And I think the commissioner's heard me whine about this more than 50,000 times. But now that first responders are carrying Narcan, there's no systematic way of reporting and collecting data on overdoses, on Narcan administration. We have, love it or hate it, we have 169 fiefdoms here in Connecticut, and I do love my adopted state. But each of those fiefdoms sort of decide what they're going to do, if anything at all. So there's no uniform data collection. And in any other epidemic, that's the first thing you do, is uniform data collection. So that's one thing I think that's really important to think about and look at. And there's no centralized coordination. There's so much happening around the state, and you've heard a lot about it today. There's no central coordination. When President Obama was in office, Michael Botticelli was the so-called drug czar. It would be great to have somebody like that at Office of Policy and Management, sort of like a Mike Lawler who does the criminal justice stuff, but someone who really looks at coordination among and across departments and communities. It would be really great to have a better handle. When we sit around our OD work group, people from all over the state, and we hear all this stuff, I'm like, we need to get central coordination. So that's another thing I think to think about, whether that's legislatively, and even the uniform data collection. We're working to figure out a way to do that, primarily with DPH and OEMS. But there's a police chief from another town who said the only way you're going to get uniform data collection is through legislation. So if we have to go that route, we will. And the last thing I think we're thinking about that needs to be fine-tuned is there's not clear legislation about who can have and distribute naloxone. And again, it's a completely safe drug. If I ruled the world, which I'm obviously working on, I would want to see Narcan in every medicine chest, in every household in the United States, in every first aid kit, no matter where it is, alongside the AEDs in airports, malls, wherever those are, on airplanes. Again, it's so safe. If he had passed out and I said, oh, maybe overdose, I give him Narcan, it's not going to hurt him. You cannot hurt somebody. You can only save a life. And I want to echo with something I think you sort of ended with, too, is, I sometimes, put myself in harm's way of, having a stroke when I read the comment threads about overdoses or, addiction and whatnot, because people are really ignorant and really, really cruel. And my response always is, and I do harm reduction and OD prevention training all over the state to all kinds of audiences, but I always try to remind people, every one of those people is somebody, someone. They are somebody, someone, and we need to keep that in mind. I want to extend gratitude to John Hampton for inviting me here today. I'm really happy to be here and always happy to work alongside you. Thanks very much.
Good evening. My name is Brad. I'm with the Simsbury Police Department. Here in the town of Simsbury, our police department, we're considered first responders. So anytime there's a medical emergency, we're the first people there to try and help that person. So a lot of what I'm going to talk about this evening is going to piggyback on what Tom was talking about in his presentation. So I think probably a good place to start is with the signs and symptoms, a lot of which Tom already talked about. I'd just like to continue with that conversation a little bit. For me, and by no means do I claim to be a physician or anything like that, but I think it helps to understand what's going on in the body to look for the signs and the symptoms. So opiates are a central nervous system depressant. So what happens in the body is you think depressant, it slows everything down. So with slowing the central nervous system, one of the results is it slows your respiratory system. So in other words, it slows your breathing down to such a slow rate that you can't sustain life. So we know that we need oxygenated blood to survive. So with the opiate, that's the result. So some of the signs and the symptoms to look for would be cyanosis, so blue lips, the fingertips, blood's not getting to your extremities, to your toes, to your fingers. The other thing to look for would be pinpoint pupils. So, and that could be said with, if you notice that in a family member, whether maybe even you're questioning whether or not someone is struggling with an opiate addiction. Pinpoint pupils when you're either outside in the sun or inside with the light is a clear indicator of being under the influence of an opiate. Our eyes, with that said, our pupils naturally contract and expand. So the thing to look for would be if they're in the sun, so in the sun or in the light, our eyes are going to constrict a little bit. That's natural. But in the dark, our pupils will expand. So if it's in the dark where someone's pupils should be large and they're constricted, that's a clear sign. So we've heard this evening a lot of talk about Narcan and naloxone. So the way I think, Narcan, as Tom mentioned, is the leading manufacturer of a drug called, and it's a tongue twister, naloxone hydrochloride. And as he mentioned, it's 4 milligrams. That is what we carry in the town of Simsbury. And we, courtesy of the town of Simsbury Social Services Department, we have been carrying Narcan, naloxone, since March of 2015. So, as a representative of the Simsbury Police Department, I'm very proud to say that we carry this to help people. And I brought an example, so if anyone's curious to take a look, we saw all the different examples up there. We have the nasal spray, which is the easiest method, the easiest tool to use. Essentially, we spray right into the person's nose, and as they mentioned, there's no chance that you're going to hurt them with this drug, with this tool. There's some things I'd like to talk about with it as far as how we store it. It has to be kept within 59 degrees Fahrenheit and 77 degrees Fahrenheit. So some people may be wondering, if you live in town, which I'm sure the majority of the people here this evening do, a lot of times you'll see that our cruisers are running, whether there's someone in there or not. We have taken steps to make sure that we keep the naloxone at the appropriate temperature so that it is effective. If it were to fall below that temperature or be left in a car on a very hot day and the air conditioning wasn't running to keep it within that threshold, within those parameters, the drug would not work the way that it's intended, the way that it's designed. So it's very important that we keep it at those temperatures. So we make sure we have policies that we have created with the Simsbury Police Department to make sure that we protect this drug, so that, God forbid, that in that instance when it's needed and we need to call upon it, we can use it and it will be effective. I would like to leave you with some statistics. We've heard a lot of statistics tonight, but I have some very, very positive statistics. In the town of Simsbury, since June of 2016, we have used naloxone 7 times. It has been effective 7 times. So that speaks volumes to how effective this tool is. So if anyone is curious, after their questions, I'd be more than happy to show you the example of the nasal spray. Thank you.
Hi, everyone. I'm going to be very quick. I'm not even on the agenda, but someone had... Thank you. Someone had told me to come here, and I just showed up. I do what I'm told. So I'm going to do 2 quick things. I'm going to be a walking advertisement because my CFO will be very happy about that, and we're going to play a little game. So the walking advertisement piece is everything that you've heard from everyone on the panel and the statistics. And again, I want to say a lot of the same things that Dave said about that you being here is very important. I don't know if you know how much it is, but it's very important. And it speaks to who you are as a person. So if you're sitting in a chair here today, it's a very important thing. I want you to know that there's treatment, that we've heard all the statistics, all the issues, but there's treatment for this, for mental illnesses, for mental health issues, for substance abuse. I will say for me at Intercommunity, which is located in Hartford and East Hartford, that we have 17 locations. We do everything from prenatal to in-school, school-based health centers, to end-of-life, to all kinds. And what we are is a community health center. So we work on, our tagline is healthcare for the whole person, because we all know we have physical health. We all know that we have mental health. Now, I know we talk about mental disease or mental defects, But we all have mental health. Sometimes our mental health is good for all of us, and sometimes it's not, and that's okay. And we know addiction plays a huge part in our communities. Whether we accept it or not, it plays a huge part in our communities. It takes a toll on us as a community, with our police officers, with members of our community, on our financial community. And so at Intercommunity, we have a whole myriad and a whole continuum of services. And what we really do is work on all of those together, because we know we can't just work on your mental health or just work on your addiction, because your addiction probably has some mental health issues going on. And that if you're not physically well, you could be taking the pills, you could be not taking the medication when you should be taking something for a mental health issue. Mental health and addiction services, as people have said but want to repeat it, they're biological disorders. Now, there's a lot of personality disorders, people who have been through trauma, and you could have a whole night talking about that. And the percentages of people in our country today who have been through serious trauma is extremely high. So Intercommunity we've been around for over 40 years. We have a detox. You can be with us through all kinds of continuum of services for almost a year. We have residentials, we have women and children's residential, we have single men and women residential, where you're going in and out, you're going out of detox into intensive programs, intermediate. You can go to one of our recovery houses. And so you can be with us, because the 4 days in detox doesn't help, because you're right up back the door and it's the revolving door. And we know that we need long-term. People need to get good foundation and good chunks of time under them, clean and sober, on medication or not, whatever it is. We have medication-assisted treatment with all our residentials. We have every mental health services that you can think of. We have lots of rehab and recovery services. We help people to get back to work, to get jobs, to build skills back up, to find out what their passion and their love is in their life, and help people to become, I hate to use the cliche, but what we all want to be. We all are members of society, and we all want to be valued and loved, and we all want friends and happiness, and we all have that in common, no matter who we are. So Intercommunity is a great place. I've left information up there. We're funded primarily by the Department of Mental Health and Addiction Services and from the federal government. Been around for a long time and have known a lot of these people for a very long time, so I'm very proud of that, and we do great work together. So there's information on the table. If anyone needs anything else or has questions, you can call me. So now we're going to play a game. David already took some of my game, so Dave. So that's all right. It's a good thing. It's actually a wonderful thing. So I didn't introduce myself. So what I'd like to ask, and the answer is yes or no, and raise your hand and keep track. We're going to have 3 questions, and please keep track. So I want you to tell me if then you got all 3 right, or you got 3 right. I want to see who the winner is. So how many people think that I have a clinical license, that I I'm a CEO of a $22 million organization of about 300 staff, that I've done it for 34 years in general, and that I also have 3 master's degrees. So who thinks that's true? Keep track of yourself. Okay? Keep track of it. So you guys said yes. How many people think that I have swum? Is that a word? Swam. We know what you mean. Swam the Long Island Sound. Very smart people. And how many people could ever see me soaked internally and externally with alcohol on a dirty bathroom floor? I want to know why. Crying for help and suicidal. So I think that just means you're here and you're in a good place and you can relate to people, which is good. All of those things, the 2 end things were true. The middle one, I swim in a pool. I don't even know how to say it right. I swim in a pool. So those things are all true. So I've been a professional for 34 years, working on different degrees, which usually I never finished a degree because my alcohol and drug addiction got in the way of it. So it took me about 20 years to get my degrees, but so I got a couple of them. I said I might as well get a couple of them and do it. And have always loved, since I was 24 years old, work with people with chronic mental illness. And then again, kind of just have worked my way up. to where I am the CEO of Intercommunity, and we're a large organization of behavioral health and addiction services overlaying primary care, because we know people with mental health and addiction services actually die much younger than the general population because they don't get the medical health care that they need. And Intercommunity, we really wanted to change that. So I tell you that story because it's so important to me that, and this is everything you talked about, so I was so happy because it made me remember when I was 2 years, 21 months sober. I tell now that I have 31 years this year sober. Sober and clean, and I'm not supposed to tell you that. I'm supposed to tell you I have today, which is all any of us have in anything in life, I believe. But it's important for me to tell because of the stigma and the discrimination, and because people don't believe it can happen to them. And do you know when they believe it can happen to them? Only when it happens to them. And so that's so important because it can happen to all of us. And I want you to know that. And again, the same, all the things you were saying, I'm not going to repeat them, but we're so right on. And for me to remember what it was to be 2 years clean and sober, and to go through all that, and to hear the stories. And I don't even want to get into any more details when I talk about my life, because there's still that shame and blame there. I'm better with it, but it's still there. What I do focus on and know about that I'm a professional. I'm a good mother. I'm very fortunate that I got sober when I was 26 before I had children. I have a second chance at life right now with my new husband, and I have a wonderful career. So, but what I think is so important, because I've done these talks before and had parents come up to me from very good schools, and Simsbury is lovely, from very good schools, and their children have died of a heroin overdose, and we've seen their picture, and it's the kid who you would never think ever would do that. I would tell you, I would never do that, but it happens. And that's why I think it's so important for us to understand it, because that trajectory, that progression happens so quick, and the odds are it's going to happen every single time. When you start doing those combinations of it's alcohol, it's fun, it's solo cups, it's partying. I thought in the 70s, didn't everyone do that? I thought everybody did what I did. I can't come to find out that not everyone did it. All my friends did it. But that it truly is a disease, and it's a disease that tells you don't have a disease. And it's a disease that in the family doesn't want to believe you have a disease. And that's what can kill people. So again, I commend you too for being here, like Dave said. I congratulate you on your journey, and you have a wonderful journey ahead, because you're starting at a great place. And to hear just the humble about working for Dunkin' Donuts, and it's a beautiful place to be, but it is a hard journey, and it can be a nightmare. But there are resources out there to help. There's people out there to help. And I just hope that each and every one of you can continue to be that, because you are tonight just by being here. So thank you.
Thank you to our amazing panelists. As I said earlier, we truly did assemble some of the best and the brightest in the field, in the profession, and we're so fortunate to have you working on our behalf. I just also want to thank both Kim and Dave for your stories of survival and hope. So inspiring, and for sharing and being so brave. And I want to open it up to questions that I'm sure some folks might have for you, if that's okay. Go right ahead, sir.
Yeah, hi. I like what Dave had to say about, there is no bottom, and that is the truth, because what we're seeing now is, since, we all know that since 1999, there's been a 400% increase in the opioid market, through the legitimate prescription pharmaceutical industry. And, from 1999 on, we've seen this, a generation of youth inundated with these substances, and it's now become the drug of choice for this generation. In addition to that, I think that the appeal and the way they market opiates to youth is when you're a young person and you're looking to get high, you're looking not to get caught. And we did such a good job of steering people away from alcohol, marijuana, and cocaine in the 80s and 90s that we were successful, but yet here along comes the opiate. And the way that the opiate appeals to the user and is marketed to the user is it's a simple little pill. It's harmless. It looks just like something your mother or your doctor would give you. It's odorless. You don't get stinking drunk. You don't get high and skunky smell on you. There's not all the. You're in control. They feel like they're in more control of the high. It's a deeper high, and it's a longer high, and they don't get caught. And they trust, like we pointed out, they trust the people they're getting it from. It's not the streets as much as it is our bathrooms, our friends, our locker rooms. You mentioned adverse childhood events and complex trauma and a series of these traumatic events and its impact on childhood development and predisposition to addiction. But one of the things I noticed in the presentation was that it was reported as adults, and when it's reported as adults, it's sort of like, okay, well, wouldn't it be great if we could have gotten to that, as these adverse childhood events were occurring, so that we could be more proactive. And these kids nowadays, for example, just this past spring break in Florida, they had already prepackaged Xanax laced with fentanyl to look exactly like the Xanax that you would buy, brand name, with the name Xanax printed right across it. They are getting these, like I said, not only is it not coming from the streets so much anymore, and from family and friends, carelessly not guarding prescriptions, but also through the internet, through the dark net. I don't know if many people are familiar with the dark net, but it is something that it's like a black market, untraceable way to acquire any kind of contraband. And as right now, it's a big head fake. They got us looking in the cities, they got us looking in all these different directions, when in fact the raw materials for fentanyl can be easily acquired and easily shipped into the United States. They're using Bitcoin, they're using PayPal, and what you're going to see is you want to have everybody on alert. You want to have police officers, you want to have post offices, you want to have anywhere that you're going to notice some sort of unusual. If you're able to access your children's cell phones and you're able to sort of pay closer attention, you see them start to develop a profile as maybe a risk taker, as somebody who's had many of those adverse childhood events that has happened to them. So you're already starting to see, like, okay, this kid's heading for some trouble. This is an at-risk youth. And the problem that we're having right now is, every solution that we come up with, no matter how great it is, and we are making great strides, this diabolical drug epidemic, and I believe it's a pandemic, it seems to be always one step ahead. And so, for example, we have now, we will limit the prescription of opiates to a 5-day prescription. And knowing how a drug addict will think, my fear is that they'll not even bother to go after the opiates anymore, and they'll go straight for the fentanyl. And that's what's already happening. They have pill presses being shipped in from all over the world through our ports, mostly through New York, where you can literally, much like the meth epidemic in the 2000s, they're easily acquired, they're easily produced, the raw materials, and they're coming in through the back door. We're just catching up to it now. So you're going to want to listen to the lingo. You're going to want to know if the kids are risk takers, if they had these series of adverse childhood events, and you want to take care of it as it's happening, not when they report it as adults. I mean, the more we know about addiction, the more we know how closely trauma is related to it. And being able to catch this and provide this kind of preemptive support, I think is what's going to do a lot of good. And I myself, I was an alcoholic, and I was fortunate to be an alcoholic because I was able to bottom out. I had second chances. I had third chances. Now kids are going out. They're going to make mistakes. They're kids. They're daring. They want to take chances. They don't think it's going to happen to them, and they're not even developing drug habits. They're not. I mean, it is possible for a kid to go out right now and make a mistake and take a laced pill with fentanyl and die on the spot. I mean, we got second chances. We got 2-3 chances to go in and out of a rehabilitation facility and detox. These kids don't. I mean, they're just being wiped out. You take it's the kill pill. I mean, it is nothing but a weapon. These pills are just nothing but, it's a weapon of mass destruction at this point. We've had 60,000 people in 2016 die of opioid overdose alone. Now, if that were any other population of people, if it weren't addicts that we treat as less than, there would be riots in the street. 60,000 people dead of anything else, and we know the direct cause of it, we wouldn't stand for it. So we've had rallies. We had a really successful Fed Up rally across the state that originated, as we know, as a federal program, and then, in D.C. And we noticed the sharp decline right after that. We stopped. I'm active in the recovery community. I go to many meetings, and I'm constant. I've lost 5 close friends. One was a valedictorian of her class and attended Yale University, and she died outside of a parking lot shooting up. And she was one of the most beautiful people, most brilliant, brightest, best people you could have ever met. And she was no junkie, She just had a problem that she couldn't control, and it's the shame and the stigma that is preventing people from getting this help. So not only have I lost 5 or 6 friends in just the last 2 years, but as a parent with 2 young children approaching adolescence, I'm terrified. I mean, you could be that one kid that goes out that one night and gets that laced carfentanil or fentanyl pill that can die. That could be my kid. That could be any kid. Because any kid's going to take a chance. Kids are going to take chances. We know that. That's a truth. They shouldn't have to die because of it, and they are being targeted. I have no doubt in my mind that the youth of today are being targeted.
Sir, we're going to be kicked out of the library soon, so I want to make sure that we have other opportunities. We've been kicked out of better places than the library, right?
I didn't realize that.
But I didn't. If our panelists wanted to respond or other people have questions, thank you for your input or comments.
Just the one thing I would say is, if we were talking 5 years ago, I would say, yeah, the drugs would be laced. They're not laced anymore. That's what it is. Heroin is not heroin. It's probably, if I was to say in the state of Connecticut, probably 80% of your heroin that's on the streets isn't laced with fentanyl. That's what they're cutting it with. Because unfortunately in the drug business, death is good. As soon as somebody starts overdosing, this is the crazy mind of the addict.
Yeah.
You go.
Yeah.
Because that must be the best stuff that's out there.
Right.
So.
I would say, too, that, the data shows the best way to at least delay experimentation of youth is parents talking to them.
Amen.
Sex, drugs, and rock and roll. I have a 20-year-old son who's in college. He just turned 20. We talked. When he was 12, we had a really in-depth conversation about sex. And covered every arena. Always had conversations about drugs and drinking when he started going to parties in high school. And basically I would say to him, I know you're going to parties, kids are going to be experimenting, people are going to be drinking, people are going to be doing drugs. Stay away from the pills. Don't ever combine things. If you're going to drink, do that. If you're going to smoke weed, stick with that. And I said, and excuse my language, but this is how I talk to him. And I go, if you see a kid passed out, try to wake them up. Don't be the asshole taking pictures and post it on Snapchat and Instagram. And if you can't wake the kid up, call 911 because you don't know what's going on. And I'm happy to say, he's in college now. He's discovered the joys of drinking weed, but he delayed that until he was in college. So I take that as a better sign than if he'd started when he was in college.
Yes, ma'am.
I've heard people say that snorting heroin is not as deadly. Is that true?
You can die of an overdose from snorting it. It's all about the potency and your tolerance and your metabolism. But I think Tom might have mentioned this, that, in terms of overdose risk, the way the drug's administered does increase your overdose risk. So if you're taking a pill, that's a little less risk. If you're snorting it, that's a little more risk. But if you're directly injecting it into your vein, that's the highest risk.
Officer.
I think a challenge that we're experiencing now is we don't know what it is. So that it could be carfentanil, in which case the snorting it or the different, taking it in routes because of the increased potency could lead to overdose. So some of the challenges, it's not clear what's what. There's some data that even marijuana, marijuana is beginning to be laced with fentanyl.
Go ahead, sir.
Just to give you an idea of one specific example, obviously injecting is still going to be your highest risk for overdose. But when I was giving you my day-to-day, when I was talking about getting up in the morning and doing 5-6 bags, a friend of mine who was my running partner when I was doing what I was doing, 2 bags, sniff, overdosed, had to be hit with Narcan 3 times on 2 bags. We used to do, not to glorify anything, but we used to do 2 bags in our sleep. And his exact words to me, no warning. No tightness of chest, no shortness of breath, just out.
Thank you. Miss, we'll come back to you. You have a question?
And you just touched on that, where it says the Narcan lasts 30 to 90 minutes. If a person's still unconscious, then you would administer another dose of it, or hopefully by then the first responders.
Officer, did you want to talk about it?
Yeah, and that's an excellent point. There's something that I would like to mention, because Tom had mentioned that the recovery position, so after the initial dose of Narcan, it's very important to put the person in the recovery position on their side. The reason for that, we've been talking about how there's no risk of administering Narcan to someone. Well, there are some side effects, and the side effect is that because the way that the neurotransmitter, it blocks the receptor sites, what's going to happen is the person is going to experience withdrawals, essentially. And not in every instance, but in most. And with withdrawals, it could be vomiting, it could be diarrhea. The vomiting, of course, is the thing that would be the risk, which is why we want to turn a person on their side. So that's very important. I forgot to mention that, so I'm glad I got the opportunity to mention that.
Thank you, officer. Yes, yes, and then we'll go over.
Okay. I'm actually with the Valley Press newspaper here in Simsbury, so I'm writing a story about this event. And the theme of the story is raising awareness, of course, and in an effort to raise awareness about alternatives to opioids and to the epidemic going on. I know that there was some mention of things like acupuncture, I believe. I'm wondering about medical marijuana, and so not referring to it in the sense of you're buying that on the street, but you're a medical patient. I know Connecticut has obviously various guidelines regarding mental health that seem to be changing, some, in flux at times, I would say. And I'm just wondering if what your perspective is on that, and also I would just add that there is a facility that I did contact Curaleaf to see if they had any input into this, and they did not get back to me, unfortunately. But I was trying to, again, just show that there are perhaps other treatment options than the traditional pharmaceutical therapies.
I'd like to address that.
Well, we need to change the way we talk about addiction and recovery, and get out of the old ways of thinking where, you have to go to detox, and then you go to a 28-day program, then you go to 90 meetings in 90 days, et cetera, One size doesn't fit all. Not everybody needs to go to detox. Not everybody needs inpatient treatment. There was a great piece on NPR where, talked about rock bottom and Terry Gross, and her own Terry Gross way was like, when did you hit bottom? And the woman said, well, that didn't happen for me. I just decided I needed to change my life. Do you go to 12-step meetings? Well, that's not part of my treatment program. I do medication-assisted therapy. I went to individual therapy. I went to support groups. So again, we have to get out of the mindset. There's people I've talked to, particularly some researchers on Yale, who've been researching on HIV and substance use disorders, and they've talked about medical marijuana as being an option. And again, one size doesn't fit all. I think Tom talked about different options for, or maybe you did, Commissioner, different options for medication-assisted therapies. For some, it's methadone. For other people, it's Vivitrol. For other people, it's buprenorphine. So, we talked on our Alcohol and Drug Policy Council work group that, we're in a society too now that we want a quick fix. Oh, my back hurts. I go to my doctor. Can you give me something for pain? My thing, if I throw my back out, I'm going to go to the massage therapist, and I'm going to go to my chiropractor before I do anything else. So we need to have different ways of thinking about frontline therapies or responses to different ailments, and then work to get it covered by insurance, because that's another barrier for people. They're like, I'd love to go get acupuncture, or I'd love to go do this, but my insurance doesn't cover it. So we need to do some really shifts here to, change that up a lot.
And I think just want to add, to really go back to why is the person using. Now, is the kid using because it's cool and we say that's the thing they all do? We have to change that. Let that not be cool, because it can be the one time when you're going to die.
It's a kill bill.
That's right. And that's what we have to change. And then for people who are using to mask the pain, we have to then look at what is going on with them, and really help them to work through that.
We always say in our harm reduction trainings, Nancy Reagan was like, don't do drugs, just say no. Drugs don't work. Well, drugs do work. That's why people do them. As Kim's saying, there's reasons for that, whether it's to deal with social anxiety or depression or trauma, or, it started as something fun, it blossomed into something else. But to be able to have those conversations in a non-judgmental way, we're changing the language we talk about it. We stop talking about like addicts and junkies and crackheads and talking about people with substance use disorders as a disease, like any other disease. I remember Representative Teresa Conroy was saying, if you go to similar to the diabetic thing, you go to the hospital with a heart attack, you're going to get a cardiac workup. Maybe there's a medical intervention. You're going to be followed by a cardiologist the rest of your life. You go to the hospital with an overdose, and for the most part, once you're medically stable, you're discharged. There's some changes happening with the recovery coaches. There's some models. I know at Yale they were doing Dr. Kate Hawk and the ED, starting people on buprenorphine when they come into the hospital, because the minute they leave, they're going to have to go get high again because they're going to be in withdrawals. So it starts that cycle all over. So what are the points of intervention that we could be better at?
You had a question, sir?
Yeah. We, I guess, are all here understanding that there is a huge problem and a growing problem with opiate abuse in the communities. And we understand that, but we would like to have people in the community, more and more people in the community, to understand what this is all about. When I walked through these doors to attend this meeting, I expected this to be packed. And the problem, I think, is that the experts are the people who are really aware of this problem, who are the experts, expect to have people come to them. It is most important for the experts to go into the community and inform them what the problem happens to be. I happen to be on the board of KSAC, and I've been to a couple of assemblies that Tom Steen has run, and they've been inordinately effective, very effective, to the extent where people have come up and just, kids and parents of kids have come up and said, what a great job you have done. He's got his own personal story, but they are now aware. There's something now in their heads that say, it could be somebody close to me, and I've got to not only use these things here to look, but to use these things here to see.
Well, that's excellent input, and a wonderful note to close on. I don't want our panelists they have to drive home, and I really want to end by, I know they'll stay after for further questions, and I just want to end by thanking each and every one of you for coming, for sharing your talent, your expertise, your knowledge, your stories, and it's as a legislator, it really is inspirational, and please count on my support as you continue your wonderful endeavors. And I'm so glad that folks came out tonight, but it's going to be also, this will be dispersed through Simsbury Community TV with all of your contact information. I hope that's okay as it goes out into people's homes. So thank you for all that you do. Thank you all for being here tonight. And again, thanks to the panelists for sticking around for further questions afterward.
Funding for Simsbury Community Television is provided in part by contributions from viewers like you. Thank you.